Hi, my name is Rebecca Rokosky. I'm a board-certified family nurse practitioner, board-certified health and wellness coach, and also a first assist. Today I'll be speaking to you about hereditary breast and ovarian cancer syndromes, how to stratify your risk for each patient, and what genetic variants play a role in hereditary breast and ovarian cancer. I practice in San Antonio, Texas, in a surgical oncology practice, and most of the patients I care for are breast cancer patients. I have nothing to disclose. The learning objectives for today's lecture are for one to learn to identify unaffected females in their practice that are at higher risk for hereditary breast and ovarian cancer. Also, what breast imaging plays a role in high-risk screening, risk stratification models, a review of pathogenic variants associated with breast and ovarian cancer, how to interpret a genetic panel, how to perform high-risk screening, and when to consider a specialist for your patient. And we'll wrap it up with some case studies. Typical versus elevated risk for breast cancer is based on many factors. And it's important for you as a practitioner to be able to give a number or percentage of how much lifetime risk is this patient at for breast cancer. And we can start this assessment by reviewing a family history. Family history with multiple patients with breast cancer, ovarian, or pancreatic should always get your attention that something may be going on in the family. Anyone with relatives that are younger than 45 diagnosed with breast cancer are concerning. And any relative, first or second degree with ovarian cancer, should be a concern and warrants further investigation. Patients can have a genetic variant from either side, the maternal or the paternal lineage. So both sides of the family should be carefully evaluated. Another part of your assessment can be based on density in the mammography by the mammographer. All mammogram reports should include a BI-RADS rating of the patient's density. Density can be evaluated as A, B, C, or D. If you look at the slide above, all the way to the left, you have a BI-RADS density A, which is completely fatty replaced breast tissue and easy to evaluate. The next picture is BI-RADS density B, which is mixed fibroglandular tissue with fat, also easier to evaluate by the radiologist. The next slide is density C, and you can see the dense parenchyma. This is density C, and then on the furthest right-hand corner, this is density D, seeing how dense the parenchyma is and how difficult, or much more difficult than it would be for the radiologist to review these patients' tissue adequately. Another question you should ask your patient is if they ever had any breast biopsies. Breast biopsy pathology, they can tell you it's simply benign, or if they tell you more that it was atypical ductal lobular hyperplasia. Anytime you hear the word atypical, it should always get your attention, and that warrants further investigation. And also, patients can have a lobular carcinoma in situ, which is not a cancer, but a biomarker that helps us predict this patient is at a higher lifetime risk of cancer. Lifestyle should also be considered. What's their BMI? Is it elevated? Do they have more than 2 drinks a day? Are they a hormone replacement user, or do they have long-term oral contraceptive use? So we can take all of these factors and create an actual percentage number. In cancer, anyone who has more than 1 to 2 times the risk of a typical patient is at higher risk. In breast cancer, if a patient has a greater than 20% lifetime risk of developing cancer, that's considered elevated. Another part to consider at how high risk your patient is do they have a genetic variant? If they have a family history, you may want to consider testing with a genetic panel. The National Comprehensive Cancer Network provides testing criteria for patients. These guidelines are updated quite frequently. So you may want, if you don't do testing often, you may want to review the guidelines. Essentially, anyone with a family known pathogenic variant should be tested. People that have relatives that were diagnosed at a younger age, less than 50, less than 45, younger breast cancers should be considered. Also, anyone with Ashkenazi Jewish ancestry is at a higher risk to have a pathogenic variant. These can be as high as 1 in 40 of your patients will test positive. Anybody with a family history of ovarian cancer, pancreatic, automatically qualifies for testing, or anyone with a history of stage 4 metastatic prostate cancer. Here's a pedigree demonstrating a family history. And these aren't quite practical in family practice due to time constraints and also what kind of software would you use. But this just gives you an overall view of a patient that could potentially present to you as a 29-year-old who's unaffected, who tells you she's quite concerned about her family's history of breast cancer and ovarian cancer. She's never been tested, and no one in her family's been tested. So if you look at her paternal lineage, which is demonstrated on the left side of the screen, you can see that her father had breast cancer. She had a paternal aunt with breast cancer and a paternal aunt with ovarian cancer, and a paternal grandmother with breast cancer. And the mother's side also gives us more information, because if you look at the mother, she only has one brother, not a lot of women in her mom's family. So it's really hard to say, when you don't have more than 2 females in a generation, would those women have developed breast or ovarian cancer? The current recommendations for breast cancer screening are an annual screening mammogram. The American Cancer Society recommends having a mammogram every other year. All of the other professional associations recommend annual mammography. How do you choose the right mammogram for your patient? If a patient is typical risk, typical density, and annual screening would be appropriate of both breasts. The radiologist can also use computer-aided detection, and that's always left up to the radiologist, or sometimes you can add that order. The other part that's quite commonly known as 3D is tomosynthesis, and this allows the radiologist to create a three-dimensional image of the patient's breast and go through the breast layer by layer. Tomosynthesis is quite helpful when you have density C or D, and you should always consider this for your patients that have more dense breast parenchyma. In 2018, the Texas legislature made it mandatory that if a provider orders 3D, that the insurance has to cover it. So there should be no additional cost to your patient. For patients that are at higher risk, an MRI with or without contrast can be a very valuable tool when you're concerned about a palpable mass that can't be seen on mammography, or patients at high risk for breast cancer. These should always be done with and without contrast, because you need both images for the radiologist to look for small tissue growths. An ultrasound is also another tool you can use for density. You can have an ultrasound every year, in addition to having a mammogram, to adequately evaluate your patients that are not typical risk and also have a dense breast tissue. With reports, the radiologist will give you 2 BI-RADS ratings. They'll give you a BI-RADS density rating, which we spoke about earlier in the lecture, and they also, at the end of the report, will give you their impression and the BI-RADS rating. A BI-RADS 1 means the patient can start routine mammography at age 40. BI-RADS 2 is everything's okay, and the radiologist would like to repeat the mammogram the next year. BI-RADS 3 indicates the patient needs to come back in 6 months because they're watching something or because your patient's high risk and they need to have 6-month imaging. Or a BI-RADS 4 is your patient needs a biopsy. BI-RADS 5 is there's a known malignancy. So it's important to pay attention to what category the radiologist has given for your patient, and you need to act upon that. The radiologists in the past years have started to include what the guidelines are, that if you have a patient with breast density, you may want to consider an MRI or an ultrasound. Diagnostic mammograms are ordered when your patient has a palpable concern on self-breast exam, when you have a concern on clinical breast exam, or the patient's high risk. Ultrasounds are always considered diagnostic and can be ordered as needed as well for any kind of palpable concern. You may want to consider including in your order that it's okay for the radiologist to do an ultrasound to completely evaluate the patient and save a callback for your office. Now focusing on risk models. There are 3 main risk models that help us give an actual number to the lifetime percentage of risk for breast cancer. And one of these risk models does include lifetime risk of ovarian cancer. The most commonly known is the Gale model. And this tool is for women that are older than 35. It will give us 2 numbers. It'll give us a 5-year number for risk for breast cancer and a lifetime risk. Patients that have had a history of DCIS, which is ductal carcinoma in situ, or stage 0 breast cancer, or LCIS, the biomarker, are not eligible to be, or it's not appropriate to use this tool for them. The downsides of the Gale model is it doesn't include paternal cancer history at all. So thinking about the slide I showed you earlier in the presentation, you would completely miss this patient's risk. This tool can be used when you want it, if you have a maternal history only, and your patient hasn't had any biopsies of DCIS, LCIS, and also you can use this when patients have atypia on their biopsy to decide if they need to be referred to medical oncology for chemoprevention, which would be a SERM or an AI, depending on your patient's age. Anyone greater than 1.7% of a 5-year risk should be referred to medical oncology to consider chemoprevention. If a patient's able to complete 5 years of chemoprevention, it decreases their overall risk of breast cancer by 45%. And that's a lifetime, 45% less. The next model is a Tyrer-Cuzick. This model is also for patients that are 35 years and older. The Gale and the Tyrer-Cuzick are both based on the same database. The Tyrer-Cuzick estimates a risk of breast cancer. It will give you a 10-year risk and a lifetime risk. And once again, if the lifetime risk is greater than 20%, this patient is at high risk. Patients that you cannot use this model on are patients that have had a history of breast cancer, DCIS, or LCIS, or if your patient has a known pathogenic mutation for BRCA1 or 2. And this can be found at ibisiconpedia.com, which you can Google and the calculator will come up. And the Gale model is in MD easily accessible online. The other part about Tyrer-Cuzick is it's more thorough. It includes the patient's breast density. You can include affected cousins. And you can also include other genes. The third model would be more appropriate used in a specialty clinic, but I do want you to have exposure to it. So it's out of the United Kingdom. It's canris.org, readily available online. So this calculates the future risk of breast and ovarian cancer. So it's our only ovarian cancer estimation tool. You can use this tool for patients that have had cancer, DCIS, or LCIS. It helps us determine what's the contralateral risk for patients. What are the chances they're going to get another breast cancer in the other breast. This model includes family history, lifestyle with alcohol use, hormone use, breast density, and you can also use pathogenic variants and get a lifetime risk for each variant. So when should we seek an expert consultation? When do we need to refer our patients out? If you have a patient who has a lifetime risk or a pathogenic variant, an appropriate referral would be to a surgical oncologist to discuss risk reduction mastectomies or high-risk surveillance. You could also always call your radiologist if you have any questions or if you have any concerns that breast tissue was adequately evaluated. Any family history of ovarian cancer should be referred to a gynecologist or also a gynecologist oncologist if you have access to that. Any high-risk breast pathology, such as atypia with atypical ductal hyperplasia, atypical lobular hyperplasia, and some other soft tissue growths that you may see on biopsy that require a surgeon, would be an intraductal papilloma. These have a 10 to 20% chance of harboring a DCIS or an invasive ductal carcinoma, and also a radial scar. They have about a 10% chance of harboring DCIS. So those should always be sent to a surgeon. Moving forward, looking at the breast cancer genes. And these aren't quite as important for you to memorize all of them or be familiar with the cancer syndromes. But most importantly, that you've had some exposure to them and that you can look them up as needed. 50% of all hereditary breast cancers can be attributed to the BRCA1 mutation. BRCA2 is 30%. And there are also some other syndromes, Cowden syndrome, Peutz-Jeghers, Li-Fraumeni, which all three of those have multiple cancers. Other high-risk variant is a PALB2, and this is a 50% lifetime risk of breast cancer, which is quite high. The lower penetrance genes, ATM, CHEK2, CDH1, NBN, and NF1, are in about the 20% range. There's a tool online called the AskToMeCalculator.org that can estimate if your patient's age and what kind of cancers they're at risk for, and will also give you the percentages. Ovarian cancer genes are similar to the breast cancer genes that you see a few of the same players, with the BRCA1 and 2 being responsible for 23 to 40% of ovarian cancers, and also PALB2. There's a Lynch syndrome, which is higher risk, and those are the particular Lynch genes, Peutz-Jeghers, and then we have some other genes listed that are lower penetrance genes, but are only concerning for ovarian cancer. So now that you've identified a patient and you want to test them, how do we interpret the test results? If a patient has a strong family history of breast cancer and a negative genetic result, one could easily say, oh, well, they're fine. There's not a problem in their family. But there may well be a problem, because it may be that you have a very strong family history of breast cancer and a negative gene a gene that we can't test for. So we simply refer to these families as non-informative. If you do have a patient that has a family member that's affected, if their mom had cancer and their mom hasn't been tested, you could recommend testing. If the mom's tested and say she has a BRCA1 gene, and you test your patient and she does not have the BRCA1 gene, then she goes back to average risk, which is quite a big change in how you would watch this patient. So when you have the genetic panel results, you will have three possible answers. You'll have a positive that the lab found a gene, a variant, which is a gene that the labs are watching and we really don't know what it means. So it's classified as a VUS, uncertain significance. 95% of the time, these variants will be downgraded to non-pathogenic. We do not base clinical decisions on variants. Only pathogenic and likely pathogenic variants. You can also have a negative report, which we spoke about earlier. Some of the labs only one of the labs, Myriad, will calculate a tyrocusic for you. So if you're testing a patient because she has higher family incidence of breast cancer, she's going to have an elevated lifetime risk. So make sure you completely evaluate the report and see, is there a tyrocusic involved in this report? And if so, did you interpret it? I've had a patient that had genetic testing at age 45, non-informative results, very strong family history of breast cancer. The second or third page of the report, the lab had calculated a tyrocusic and it was 45%. 3 years later, this patient presented with breast cancer. Here's a sample of a genetic panel report. Years ago, when genetic testing was extremely expensive, the provider would have to guess looking at the family history, what genes should they include in their testing, or should they just look at one gene? So fortunately, genetic testing has become so affordable that we can do panel testing, which means there are multiple genes on the panel. This is a Myriad panel. This is a patient of mine who was diagnosed with breast cancer. She did have a family history of about, believe it or not, 6 uncles with colon cancer. A panel test on this patient revealed that she had a Lynch syndrome gene, which explains all the colon cancer in her uncles, but doesn't explain her breast cancer. But it's an incidental finding. So now we know this patient has Lynch syndrome and she needs to have close follow-up with her gastroenterologist. Doesn't explain her breast cancer, but this is a possibility. When you're ordering genetic testing on your patients, you could have a gene that you're really not expecting. And panel testing is also helpful because it covers the entire family, no matter if they have colon, pancreatic, ovarian, breast cancer, kidney cancer, just about all the cancers. So moving to our case studies. I have a first patient. It's a 37-year-old female, presents to you for her well-woman exam. She's interested in birth control. She is not quite at 40 years old to start screening mammography. On family history, she tells you that she has a maternal grandmother who had breast cancer at age 77, which could be a spontaneous cancer, sporadic, not genetically caused. So that could be okay. One relative is not going to make you at higher risk. May elevate it a little bit. But then she tells you about her dad's side. Her father had prostate cancer at age 67. She had a paternal aunt that had ovarian cancer and also a paternal aunt that had breast cancer that died of pancreatic cancer. So if you go back to your NCCN guidelines, this patient easily qualifies for genetic testing and should be tested for multiple genes if you look at all the cancers in her family. And here are your results, and they're negative. So not helpful for us to explain all the cancers in this patient's family. So just not informative. We're not going to let our guard down on this patient. We could offer her, can her dad be tested? Was her dad tested? And if not, is he willing to be tested? And if so, you can refer to a genetic counselor for testing. Because if the dad has a pathogenic variant and the daughter doesn't, she's going to be, once again, at average typical risk. If the dad is negative, then we don't know what's going on in this family, and we don't have a genetic test for it at this point in time. So we would start high-risk screening on this patient. And at age 37, this patient is old enough that you could do a mammogram, MRI, and ultrasounds. Our next patient is a 52-year-old that has a palpable concern on self-breast exam. She's a density D, she's a BMI of 31, and she has no family history of breast, ovarian, or pancreatic cancer. What are we going to do for this patient? Well, let's start at the top. She definitely needs a diagnostic mammogram and an ultrasound, possibly a biopsy. If either one of these show anything, you could also consider an MRI, which would be very appropriate based on her breast density. She does have some risk factors for breast cancer, which is a BMI of 31. Does she qualify for genetic testing? No, she's not a candidate. So what we need to do is address her density and her palpable concern. Case study 3. You have a 47-year-old woman that presents for a well-woman exam. She tells you she has a family cancer history in her sister, mom, and her grandmother, all maternal. So here we have one lineage with lots of breast cancers. She recently had a bilateral screening mammogram, which was negative, and she has a density C. So what are we going to do for this patient? So we should consider genetics. She easily qualifies with 3 effective relatives on the same side of the family. Screening mammography for this patient is inadequate, and we need to adequately assess her density and all of her breast tissue. So this patient, if we did a Tyrer-Cuzick, would probably be in the 30s or the 40s. So you can order an MRI, a diagnostic mammogram, and also an ultrasound. The American Cancer Society states that we should order MRIs on patients with 20% lifetime risk or greater for breast cancer. So she easily qualifies for high-risk screening, and she also qualifies for genetic testing. So you order a diagnostic mammogram and an ultrasound. And the benefit of doing a mammogram is that it evaluates for microcalcifications, which are breast tissue changes that tip the radiologist off that something's not quite right. And the MRI is very sensitive for soft tissue densities. And that's why in high-risk screening, we would alternate between an MRI and 6 months later do a bilateral diagnostic mammogram with an ultrasound as needed. So that would be a good place to start with her, would be to do a bilateral diagnostic mammogram and also panel testing for genetics. And here are her results. So this patient has a pathogenic variant, a BRCA1, which we know is responsible for 50% of breast cancer genetic-based cancers. We know she's a strong family history, and this patient needs to be referred to a surgical oncologist to be evaluated for high-risk screening, risk reduction mastectomies. If she's not interested in that, she can also see a medical oncologist for chemo prevention. If you look at her report a little more closely, you can see she has a positive result, and it gives us some more information about the gene, that it's autosomal dominant. So when we see autosomal dominant, we know it's a 50% chance that this patient's offspring would have the BRCA mutation as well. Also think about that there is a VUS also reported in this panel. So if you look under the gene variant, it goes through the BRCA. It's a deletion, which is not quite important unless you're really into genetics, and it's a heterozygous. So you can have genetics are like a pair of shoes. You get one from mom, one from dad. So this lady just got a bad copy from mom, but a normal working gene from dad. And the lab classifies it as pathogenic. And below the BRCA1, there's a VUS, a PDGFRA, and it gives you an actually genomic address, the zygosity, which is heterozygous, and its uncertain significance. So this is also known as a VUS, and it's not going to affect our patient care whatsoever. When VUSs are reported by the lab will pledge to the patient that if it does get upstaged to become a pathogenic variant, they'll notify the patient. And they'll also notify you as the ordering provider. But there's a 95% these will be downstaged. And once again, it's a VUS. We don't make clinical decisions on VUSs. This concludes this presentation. I hope it's helpful. I hope you're able to create a network in your practice, that you have colleagues that you can call and ask. Don't be afraid to call the surgical oncologist, the breast center. Find out as much as you can about your patient. Always listen. Always update your patient's family history. Let your patient know that's important. And especially if they're telling you they're really concerned, always consider, does this patient need genetic testing? And if so, if they don't meet the NCCN criteria and they're quite committed to being tested, you can always offer them genetic testing out of pocket, which most of the labs will offer for about $250. If you have patients that have had direct-to-consumer testing like Ancestry, 23andMe, and it's come back with the genetic variant, always repeat the test with a genetics lab to make sure that that was a valid result. Thank you for your time. I hope you enjoyed the lecture.